grande entusiasmo que damos início ao Simpósio Internacional de Anestesia da SAESP. Hoje, reunimos profissionais de renome mundial para compartilhar conhecimentos e experiências que certamente enriquecerão nossa prática clínica. Este evento é uma oportunidade única para discutirmos temas cruciais como a gestão do sangramento perioperatório, o PBM, a anestesia regional e a abordagem da dor. Cada um desses tópicos é vital para a melhoria da segurança e do conforto dos nossos pacientes. Contamos com a presença de palestrantes internacionais que trarão suas valiosas perspectivas e inovações. Após as apresentações, teremos um momento de interação, onde os debatedores e público poderão discutir e esclarecer dúvidas, promovendo um diálogo enriquecedor. Agradecemos a todos por estarem aqui e esperamos que este simpósio possa inspirar novas ideias e práticas que impactem positivamente a anestesiologia. Vamos fazer juntos deste evento um marco na nossa formação e prática profissional. Sejam todos muito bem-vindos.
Thank you very much for the invitation. The topic today, I'm going to talk about a block called pericapsular nerve block, which I have a lot of interest in this. So I'm going to share with you what I learned in the last 5 years. This is the Scotia slides, other than the equipment, but just want to give you some warning. The block that I'm going to talk about, the name of this procedure, share the same name of the speaker. Back to 2018, when our group, we described a block when we aligned the ultrasound probe between the AIIS and the iliopubic eminence, and direct the needle between the psoas and the ilium. And when we achieve a lift of the psoas tendon, we find that there's a dramatic drop in the Peng score for someone with hip fracture. So this is some of the result. On the left-hand side is the Peng at rest. The blue bar is a Peng score before the block, and the orange is after. So obviously, you don't see the orange right after because they have no pain. But the pain with movement, they still actually have a substantial decrease. When we talk about the effect size, we are talking about a drop 7 out of 10. So it's a significant drop in the Peng score. Compared with the literature, the fascial iliac block, they also have a good drop, is around 3.6. So it's much more dramatic for the Peng block. So what's the rationale? Because between the AIIS and iliopubic eminence, there's a lot of articular branches from femoral nerve. There's also articular branches from the accessory articular nerve. On the right side of the diagram, you can see the red circle is the obturator foramen. It sends some articular branches inferior to the inframedial acetabulum and supply the inferior capsule. So we believe that actually is a spread of the medication around the capsule that block all the articular branches that approach the capsule. So what I'm going, and since then we just somehow is getting a very popular across the world, and we're very thrilled about this. But let's talk about some of the lessons. The first thing I want to talk about the spread is it really what we think is. Now, it's not me, it's a Denmark group. The Denmark group, they define there's a plane called iliopsoas plane. Look at the left side here, you look at my cursor. It's a plane between the iliacus muscle and the iliofemoral ligament. So they define that space, and they find this actually a very consistent space. They even have a block based on that space called iliopsoas plane. The Peng block here is actually the most cephalic part of the space, and we inject there. So we share the same space. Just actually, when you put the muscle, is actually between the iliacus, and the blue one is the iliofemoral ligament. But if you inject a small volume, 5 cc, usually it will restrict to that space. It will not go medial because it's blocked by the psoas bursa. It will not go lateral because it's blocked by the rectus femoris. It's the theoretical space and that it doesn't go beyond. But when we inject higher volume, we know that it's not true. When we inject a high volume, it goes cephalic and caudal. The caudal is very important because it blocks even more branches of the femoral nerve. Then when we inject even from 10 cc to even 20 cc, we find that the literature suggests it spread even more medial and cover the branches sending from the obturator. So, and this is actually what we say this is a spread. So there's a therapeutic and a good spread, but there's something we call undesirable spread. Undesirable means actually, here is a desirable. We spread along the plane here. Undesirable is when you have a poor technique, you didn't even puncture through the psoas muscle, that it will spread intramuscularly and spread to the femoral nerve. Or there's some anatomical variation, or you give such a high volume. The medication can go between the plane between psoas and peteneus and dive underneath the fascia iliaca, or actually there's an intramuscular satin between the different iliacus muscle, and it dive under the fascia iliaca and spread to the femoral nerve. Or in some skinny patient, when the psoas muscle is so thin, even though you achieve in the plane, we call the Peng space, but the medication can spread along the needle track towards the fascia iliaca and then femoral nerve. We call this undesirable spread. So in summary, basically, the spread of this is volume dependent. The more, the better the spread. But then the more it spread, well, it achieves the therapeutic, medial, and caudal, but it can have some undesirable spread. We know that it's actually confined, it's volume dependent. So what is the optimal volume? We are going to talk about this. But before we talk about this, I just want to show this article just published in Regional Anesthesia Pain Medicine. This article actually talk about they use in human being, they put the needle and they inject with some contrast mixed with a CAT scan, and then review with a CAT scan. And they say pain block does not exist. Everything that it works is through the intramuscular. So the muscle block the nerve. I have no idea what they talk about. So they say 100% of those pain block, they are actually inside the muscle. So if you have, so for the interest of time, just I would like you to read this article. I respond to them. I call this is rationale effect. Rationale effect. So what is a rationale? You read about the article, you know. So I raised 3 points. And never in any history something like this. In history of the study of the spread of the fascial plane, it always have 2 things. One is the spread is variable. It may not be what you think, but it just actually always have availability. But there's one thing for sure. They all confirm there's such a plane, because obviously people have studied there's a plane before we put the plane block there. So it never have any history in any plane block spread, and then you confirm there's no such plane, which basically I find is ironically. And the second thing is they say, well, the reason that you cannot achieve because the psoas and iliacus muscle is adherent to the bone. All right. So first of all, actually, the plane here, we talk about iliopsoas plane. Iliopsoas plane is well defined by the anatomists, well respected in Europe, Bernard Morigo and the Denmark group. And then the psoas bursa is well defined by the anatomists 100 years ago. So there's a space there. I mean, have been well described. I don't make this up. So then they say, well, in some patients, they actually say, I can inject. Okay, so look at this. There's a picture after I asked them. They show, yeah, so they can actually see the psoas leaf. So that means they have a space, and then they say there's no space. I don't understand what they mean. The third actually is, I think, the reason why they have discrepancy because they use a CAT scan contrast, which basically occupy 10% of the local anesthetic. So even though the needle may be in the right space, but it changes the viscosity of when they do the hydrodissection. But the viscosity of the injectate may actually backtrack to the muscle because of viscosity. The contrast occupy 1%, as opposed to a lot of those MRI studies that probably done, they actually use 0.1% of the contrast. You don't need a lot of contrast. So I think there's a discrepancy is because of a change of viscosity from the CAT scan. All right, that's enough garbage about this. I don't believe this study. Now let's talk about the optimal volume. What's the optimal volume and is it the motor springs block? Just to let you know, when I first developed this block, I use it for diagnostic. I use 0.5 to 3 cc, 0.5 to 3 cc. But in regional, they use 20 cc, 20 cc. Wow. So this actually is a huge volume. So, and then that's report of a conscious of weakness from 0 to even 45%. Well, let's dive deep to this here. This is a type table in my article. I summarize, compare the Peng block with no block, like can be a sham block, placebo block, or a per-articular injection, intra-articular injection. So that they suppose not to have any motor weakness, okay? So then compared with Peng block, all the 7 studies, they show there's no difference. in the motor weakness. So I think the Peng block surely is a motor sparing block. Now, the study that report the highest incidence of the quadricep weakness, 45%, was from this study. I love this group, from Chile group. They compare Peng block with suprainguinal fascia iliaca block. The fascia iliaca block obviously have sky-high motor block, but they say actually in Peng block is 45%. So a study, they have another study, the same group, this one. They say because of a high incidence of the motor block with Peng block, okay, they want to see whether but infiltrating around the joint is better. Okay, makes sense. Well, if you don't like Peng block, you want to find another one to compare. But shockingly, actually, I want you just to make sure you understand. They find that the motor weakness with the exam of the quadricep weakness is 33% in the articular infiltration compared with Peng block, which is 20%. So basically, the periarticulars have 0. They have even higher motor block than Peng block. There's something we'll have to do with the assessment, but also this is their wording. They say quadricep weakness can be multifactorial. Now they are talking. May not be really necessarily related to the femoral nerve block. It can be related to the pre-existing pain or arthritis that inhibit the ability to use the quadricep. So you can see actually, I think actually is truly a motor block. And there's a study, I look at them, what is the femoral nerve sparing? This study is actually in Thailand. I just want to make sure you know it's in Thailand. So the study actually, if you inject around 13 cc, you won't get any spread to the femoral nerve. But I've been to Thailand, the BMI is so low, and the psoas muscle and iliacus muscle is so thin. I would say you take it with a grain of salt. The second thing is actually they use a staining to quantitate the femoral nerve block. We know that it's not true. Now on the right side here, you see a deep staining, probably is a femoral nerve block. But they say even a tiny touch of a bluish color in the femoral nerve is also called as a femoral nerve block, which is not true. So I think 13 cc is a bit overestimate. So in general, I think, as usual, we should not just use 20 cc. I think based on literature, I think 15 to 20 cc is a range. But we don't know whether how good they are, because virtually all the studies they use 20 cc. But even 20 cc, they don't have a motor block. But let's face it, in clinical practice, even though something very safe, 99% safe, there's always an outlier. There's some patient that you use case report to show they have some motor weakness. Should we go to 13 cc? I think it's too low for the reason I explained, because of the BMI, because of the staining, the assessment. I think in regional anesthesia, one size should not fit all. We should bounce between 15 and 20 cc. Depends on the body habitus. There's a very tiny lady, we scale down to 15 cc. And we see the real-time spread. As soon as you see actual spread intramuscular or actually between the platelets, you just hold off or change the needle direction. The type of surgery. If a patient have a hip fracture, it's not going to ambulate in the next 12 hours. It doesn't really matter motor sparing or not. And also recovery plan. If you don't have a day surgery for total knee, total hip, you don't really need to worry about too much about the motor sparing. What you really want to is actually make sure that you have a good volume. All right, so after all this basic, we talk about some outcome. So first of all, does Peng block work in the post-traumatic pain? Not post-op, post-traumatic pain. So this is actually one of the very good study in Singapore, from Singapore. They actually show that actually is very confirmed what our case report. In the first 24 hours, it actually dropped those pain score substantially. And it's confirmed another study, all right? So it's not just actually drop the pain, but also allow the patient to turn for spinal. It's actually significant. People actually even study this. They compare with some other block. And they have a scale. So 0 is you cannot turn the patient cannot be turned because so much pain. 3 is the patient can just turn themselves with the hip fracture. So, and 2 is actually they can turn themselves with a little bit discomfort, but no drug required. 1 is actually where they still need 1 drugs. So, and they compare with what we call fascia iliaca block, which is basically a femoral nerve block in that case series. Most of the patient is between 2 to 3. So that means actually the patient can turn themselves after Peng block. And there's another study confirmed basically the same. So not just one study, two studies confirm the same idea. Okay, so summary, I think the post-traumatic pain, we have a fracture, put the Peng block. You certainly actually can decrease the dynamic pain score between 12 to 24 hours. And it's so dramatic that you can actually allow them to turn the patient for spinal. All right, so quickly go to, what about the post-op analgesia after hip fracture? We don't have a controlled trial, but we have comparative trial. Compare Peng block with femoral nerve block, compare Peng block with the fascia iliaca block, but infrainguinal. So it's a famous study from Australia compared with femoral nerve block. We call the pragmatic trial, 60 patients, good sample size. Pragmatic means actually they just have one is a femoral nerve, the other group is a Peng block. Everything, let it go. So let it go. So they can be general anesthesia, the fracture can be extracapsular, any type of surgery, general anesthesia, spinal. But no matter what, they show a very decent actually improvement in pain in the first 4 hours. So this actually is very important. Well, remember they do the block before the surgery, and even the first 4 hours after the surgery, they still have a good pain control compared with the femoral nerve, which is in Australia, they say is a standard of care. But hang on a second, it's too good to be true. It cannot be in all patients, all right? So they do a post-hoc analysis. They find that actually for those with hip arthroplasty, hemiannular arthroplasty, it worked. But for those with DHS or dynamic hip screw or IM now, which basically the incision, everything is outside the capsule, it shouldn't actually cause pain. So it makes sense. So it mainly work for, the advantage is mainly for those hip arthroplasty or hemiannular arthroplasty. What about compared with infrainguinal fascia iliaca block? So I'm not going to the detail, but this is actually a fairly decent study. And they show the pain in the first 24 hours dropped by 20 out of 100. And also there's a significant decrease in the OPR as well. All right. And not just one study, another study again show the same thing. So I'm not going to bore you with this, but I'm going to the conclusion slides. I would say any comparative trial in hip fracture, compare Peng block with femoral nerve block and the fascia iliaca block, the Peng block always show some superior analgesia. Well, hip fracture is one of the model. The other common surgical model is total hip arthroplasty, and is well studied, and there's so many trials. And that is actually when I performed the review, there's actually 12 trials, and now even more trials on this. Let's look at those we call placebo control on control trial. There's 3 of them. I just show one of them. They actually here is show the Peng block with no block. The advantage is actually fairly huge in terms of pain score. This is actually the black color is a Peng block. The pain score from the control is much higher, especially in the first 24 hours. And the analgesic, the number of tablets, you can see is substantial change as well. And it's actually reproducible in other studies. But I want to actually show you this study, quite interesting. This is the Peng block versus control, but not just on the pain, but they look at the recovery. They use the quality of recovery 15, QOR 15, and they find that actually at 24 hours, the recovery is much better with Peng block compared with no Peng block. And not just the overall scale, but all the subscale. It beat every single part: pain, physical independence, comfort, emotional, psychological support. Peng block is much better. Now, the advantage is around 25, 26. So what does it mean by having a score better than 25, 26? Let's give you some idea. The minimal clinical important difference is 8. So we are talking about 3 times more than the minimal clinical difference by doing a Peng block compared with no Peng block in the recovery. So we know that Peng block have to be very good. Okay, what about some comparative trials? They compare with a superfascia iliaca block. Now, I just want you to, so this all block find similar pain score. The other 2 actually find, Peng block is better. Now, I just want you to caution about this. First of all, the superficial iliac block is not really it doesn't have all the advantage as a superficial iliac block if you don't inject 40 cc or more. Only 2 studies actually use 40 cc. So that means the other is not really superficial iliac block, it's infrainguinal. So that means not only 2 studies are superinguinal. The 4 studies are not truly superinguinal, they are infrainguinal. And we already know that Peng block is better than the infrainguinal. And one even use a catheter, and some of them they use a lateral femoral cutaneous block. But most important is from what we learned here. None of the study show that the superinguinal fascial iliac block is better than a Peng block. None of them. But almost all studies show that the Peng block is much more motor sparing. So the 2 blocks, superinguinal and Peng block, they are very similar, but actually Peng block have much lower chance of motor weakness. So you make a judgment. When you compare with the intraarticular injection, so as expected, we don't see much difference. Okay, so I'm going to talk about this. So basically, it's a summary for total hip replacement. All the control trials show there's analgesic benefit, a Peng block, and it translates to a superior recovery milestone. This is important. It's not just a change in the VAS score, the Peng score 1 or 2. It changed the recovery profile 3 times more than the minimal criteria for clinical significance. Compared with the superinguinal fascial iliac block, there's no study shows superinguinal is better than Peng block. You have to show me one. Well, then you can use both, but then Peng block overwhelmingly preserve the quadricep strength. Compared with the intra-articular block, well, Peng block is pericapsular, is basically pericapsular infiltration. So we should not see much difference. All right. Finally, I still have couple of minutes. I want to show you what about hip arthroscopy. So the hip arthroscopy, actually 2 randomized control trial, one study only 30 minutes, so no difference. The other study longer in 24 hours, and there's a delay benefit. But the story is not that, this is a summary slide, it's not that clear. We still don't know whether it's good for hip arthroscopy because the pain from hip arthroscopy is not just from the pain inside the joint. They put a traction there, so the pain can be from the gluteus muscle and thigh muscle. But then they also actually have the extravasation of the injection. So they can actually cause a lot of pain and cause a soft tissue swelling. They have been well shown for any hip arthroscopy. But most importantly is, if they extravasate, they may wash off the local anesthetic around the capsule. So the Peng block may not be that evident. So we still don't know yet, but I think more studies need to confirm whether there's any role in hip arthroscopy. So here is my summary slide. I describe with you the spread, the optimal volume, and I confirm it's a true motor sparing block, although there's some outliner. And I talk about the hip, the efficacy in post-traumatic pain in hip fracture, post-op pain in hip fracture, and the usefulness of this in hip arthroplasty. The hip arthroscopy, we don't know yet. So we will see, but there's a lot of study keep going, so we will learn more and more about the Peng block. Thank you very much.
Bom dia a todos, pessoal. É um prazer estar aqui com vocês para responder algumas dúvidas ou questões que vocês tenham. Aqui com a gente também está o Dr. Leonardo Reis. Sintam-se à vontade de mandarem questões para o chat ou perguntar aqui para a gente.
Bom dia, pessoal.
Léo?
O Dr. Peng fez uma excelente apresentação sobre o bloqueio, né? O Peng Block hoje se tornou referência em bloqueio de quadril, né? Então, acho que a aula dele já elimina muitas das questões que vocês poderiam ter, mas estamos aqui abertos para discutir, aguardando aqui no chat, tá? O principal ponto que ele destaca, então, enquanto não chegam as questões aí, é que é um bloqueio altamente eficaz para cirurgia de quadril, tanto fratura quanto arthroplastia, principalmente que é um bloqueio poupador do quadríceps. Então, a gente não tem fraqueza de quadríceps, né? Na verdade, quase nunca. Esse quase, quem faz muito Peng talvez já tenha tido um outro caso de bloqueio motor, e aí ele explicou naquele slide que você tem uma dispersão entre os planos musculares, podendo atingir o femoral, e você pode ter uma dispersão também pelo trajeto da agulha pegando o femoral. E aqui temos a primeira pergunta do Dr. Márcio, se a gente utiliza catéter no Peng. Márcio, eu acho o catéter no Peng excepcional, tá? Porque ele permite que você estenda aquela analgesia no pós-operatório, né, por os dias subsequentes, poupando a motricidade. Na nossa experiência, a gente faz muito isso lá na Santa Casa de Valinhos, né, onde é um hospital que eu trabalho, que tem SUS, os pacientes ficam muitos dias internados, e a nossa experiência é que tem uma analgesia muito boa com catéter, tá? A única coisa é que alguns pacientes com catéter, principalmente se a gente usa doses altas, e quando a gente vai repetindo, e nosso protocolo lá é fazer a cada 12 horas uma dose de 20 ml de anestésico local no catéter, alguns pacientes acabaram desenvolvendo fraqueza muscular, poucos, mas alguns desenvolveram. E aí pode se explicar pelo aumento de massa do anestésico local, ou pode se explicar também pela dispersão pelo catéter, né? Ele acaba mantendo um pertuito ali, como o Dr. Peng mostrou no slide dele, tá? Mas é muito bom e muito eficaz no controle de dor. Tem vários catéteres passados no Peng Block.
Eu acho que
Inclusive,
desculpa, Léo, mas eu acho que uma boa interação do catéter é isso mesmo, você consegue diminuir um pouco o volume inicial, e se você precisar complementar, você pode usar com volumes menores o catéter. No caso de vocês só fazem infusão a cada 6, 8 horas, ou
não,
quantas infusões após o do catéter?
não, 12 horas, 12 horas. A gente não usa bomba, mas a gente acabou percebendo que, bom, primeiro bomba tem todo aquele problema, inclusive passando SUS, locomoção, tudo isso, então, né, fica aquela parafernália do lado, e a gente percebeu que o single shot dava em torno de 16 horas de uma analgesia muito boa, depois o paciente tinha dor. Por isso que a gente padronizou para 12 horas, então no início e no final de cada plantão é feito o cateter. Tá? E é isso. E uma dica é o seguinte: a gente já tentou fazer isso com o kit contínuo, né, o duplex contínuo, mas a agulha é muito mole, então algumas vezes é difícil você orientar bem a agulha, e teve casos que a gente teve que usar uma agulha guia. E a gente acabou percebendo que a agulha peridural, principalmente a pediátrica, é mais fácil você alocar o catéter. Ela é mais fácil você posicionar e alocar o catéter. Olha aqui, eu perguntando se a gente faz o Rodrigo, olha só a pergunta, se em cirurgia de artroplastia de quadril, a gente faz o PENG associado a hack ou anestesia geral. Na maioria das vezes eu faço com hack, é um dos hospitais que eu trabalho, tem uma população, um público um pouco mais, digamos assim, exigente, né? Ali todos chegam na sala pedindo, eu quero dormir, aí a gente acaba fazendo o PENG com geral, mas na grande maioria das vezes eu faço o PENG associado com a hack anestesia, e faço logo após a hack, né? Ou logo após a intubação, então antes do início da cirurgia. Rodrigo?
Não, eu acho que é uma boa opção, sim. É claro que todos esses tipos de bloqueios regionais, quando a gente pensa para fazer no nosso paciente, a gente precisa conhecer um pouco o cirurgião também, né? Porque
Sim.
dependendo do tempo que o cirurgião leva, a quantidade de fluido que ele vai utilizar, isso vai causar distensão, como o doutor Peng falou na aula dele. Isso vai aumentar, e tem o estiramento também para poder fazer a abertura do espaço para fazer a artroscopia. Então, é uma coisa que a gente precisa levar em conta. Então, eu acho que é uma boa opção, tanto para anestesia geral quanto para raquianestesia, e sem dúvida nenhuma melhora a qualidade de controle de dor pós-operatória.
O Márcio está perguntando se a gente adiciona algum adjuvante no PENG e se usa opioide na hack. Márcio, eu sou purista, eu não uso adjuvante em bloqueio, não. Até porque eu já vou ter 24 horas aí de analgesia, né, 16 muito potente, então o adjuvante tem pouca efeito nisso e pouca evidência na literatura, principalmente eles não são liberados pelo FDA, né, com exceção da hidrocortisona. Então eu não uso, e até porque com catéter acaba essa questão, né, de aumentar, você aumenta indefinidamente a analgesia. E na hack a gente pode usar opioide, porque o Peng Block dura mais que o opioide, então eu teria todos os efeitos colaterais do opioide e não vou ter o benefício. Então a hack sem opioide e o Peng. Rodrigo?
Aqui é a mesma coisa. Aqui, como tem esse problema de muita risco de liability, de processos, então a gente tenta utilizar o que está descrito na literatura, e assim a gente vê as últimas publicações de adjuvantes. Você pode lançar a mão da dexmedetomidina, mas o pessoal, dependendo do tempo, por causa da duração do bloqueio, tem usado menos mesmo os adjuvantes, e só associado ao bloqueio regional mesmo.
Perfeito, pessoal. Nosso tempo está quase se esgotando. Quem tiver pergunta, por favor, mande agora.
Léo, em algum dos hospitais que você trabalha tem bomba elastomérica ou bomba contínua para fazer utilizando os catéteres, não?
Temos bomba não elastomérica, temos bomba contínua, mas eu confesso que nesse tipo de técnica, eu prefiro bolos intermitentes. Inclusive, eu acho que fica mais prático. O medo que eu tenho da bomba também, Rodrigo, que quando a gente não está de plantão e o doente não chama, né? O paciente fica meio largado lá, ninguém vai ver, porque ele está bem, está quietinho, né? E eu acho que o paciente com bomba tem que ser até mais visto que o paciente sem bomba, né? Ó, o Márcio está perguntando se faz o antibiótico antes do PEG. Márcio, eu sempre inicio minhas cirurgias com um soro de 100 ml, onde eu coloco o antibiótico. Então, assim que eu punciono a veia, seja com técnica regional ou geral, eu já coloco nesse soro de 100 ml um antibiótico ou um anti-inflamatório, alguma coisa. Então, em todos eles, mesmo na anestesia geral, vai ocorrer isso até antes da punção. Eu faço isso para todo mundo, para evitar dar muito volume para o paciente do antibiótico e ajuda a passar isso mais rápido, né? Rodrigo, acho que essa é mais para você, ó, sobre a dexmedetomidina, quem tem evidência.
Sim, eu acho que é uma boa medicação, acho que aumenta o tempo de ação do bloqueio, mas a gente vê que talvez nem precise, porque você só aumenta o tempo e às vezes esses pacientes não precisam da associação de um adjuvante. Mas sim, é uma opção que você pode lançar no caso do seu hospital. Se você não tiver, por exemplo, catéter, você pode lançar a mão da dexmedetomidina e você vai ter um aumento do tempo de analgesia. Uma outra coisa que eu queria só chamar a atenção para a pergunta do Márcio, do antibiótico, é extremamente importante você fazer o antibiótico, mas a gente precisa lembrar e focar um pouco mais no preparo também, fazer tudo estéreo. A gente tem uma publicação recente que saiu, então você deve utilizar o gel estéreo, você deve utilizar a capa de ultrassom. Então é importante não só utilizar o antibiótico, mas também fazer asepsia, antisepsia e manter o bloqueio sobre campos estéreis e preparado para ser tudo estéreo.
Pergunta do Márcio, se faz o PENG no início ou no final da cirurgia? Márcio, essa pergunta é muito boa. No final da cirurgia, talvez você tenha um pouco de edema, infiltração no campo, você tenha um pouco de manipulação ali perto, pode ser que fique mais difícil fazer esse bloqueio, tá? Inclusive porque vai ter o curativo ali, né, da área cirúrgica, e eventualmente o curativo entra um pouco na frente do teu plano de punção. Então, eu faço sempre no início da cirurgia. E se você usa um catéter, fixa com curativo plástico, estéreo, que eles vão ter que pintar por cima e tentar jogar esse catéter mais medial, tá? Se você usar catéter. Se não, faz só o bloqueio antes do início da cirurgia, mas porque depois pode ficar mais difícil fazer essa punção.
Eu concordo com o Léo, acho que tem que ser no início, e até porque às vezes se você associar com geral, o ideal é fazer com o paciente mais acordado, que ele pode interagir com você, né? Então acho que é mais seguro, mas sem dúvida nenhuma é muito mais fácil você fazer sem a dilatação após a artroscopia.
Isso. Pessoal, muito obrigado pela participação de todos. Espero que vocês tenham gostado. Foi uma aula excepcional do Dr. Peng. O nosso tempo está esgotado. Nós vamos seguir com os demais temas da programação. Rodrigo, muito obrigado. Márcio, obrigado.
Obrigado, Saes, pelo convite. Obrigado, Léo, pela parceria de sempre. E espero que vocês tenham gostado. Grande abraço e continuem assistindo o Simpósio Internacional da SAES. Obrigado.
Obrigado, pessoal. Obrigado, Saes.